Ladies and gentlemen, colleagues and friends, welcome to the third webinar in the Strengthening and Sustaining RAMCA Systems in Sub-Saharan Africa webinar series, co-led by EXA Health Community and University of California, San Francisco, together with their partners in the region. Generous support for the series is provided by USAID Health Evaluation and Applied Research Development Project, led by University Research Co-Head, supports global implementation science partnerships that accelerate the use of evidence for policy and program improvement. We are pleased that you all could join us today for one of our most popular topics. Our webinar will provide an opportunity to explore evidence, experiences, and perspectives on promising approaches and routine monitoring and evaluation for respectful maternal care in Africa. Over the next hour and a half, we will hear from experts across Sub-Saharan Africa about how they have sought to overcome these challenges and the lessons learned along the way. We encourage you to participate and ask questions using the Zoom chat function. We will be monitoring the chat and have reserved some time at the end of the webinar for a panel discussion. To begin the webinar, I would like to welcome Professor Yoso Dambisia, Director General of the EXA Health Community, to formally welcome you to the webinar. Thank you all for joining us today.
Thank you very much, Puleng, for asking me to welcome everybody to this. Good morning to the colleagues in the United States. Good afternoon, good evening to the colleagues on the African continent. I'm very happy to note that I've been able to join you this time. I've missed a number of the previous sessions due to conflicting schedules, but as Emily and colleagues from URC will attest, this is an issue that is close to my heart. And I thank Puleng for keeping me in the loop of all the developments. It will be very exciting to hear how those of you at the coalface of ensuring that our mothers get the best quality services in the process of accessing maternity services, especially during these challenging times with the corona pandemic, where a lot of resources have been diverted to the exclusion of many of the other services. So I look forward to hearing from the experts on the panel. I welcome you very much, and look forward to learning as the morning progresses. Without taking too much time from the experts, allow me say karibuni sana and let you get on with the show. Thank you very much.
Next, to welcome Dr. Raj Stevenson.
Esteemed panelists, participants, and hosts, everyone, good morning, good afternoon. It is a pleasure joining this important meeting convened by USAID's Health Evaluation and Applied Research Development, HERD project, led by University Research Corporation and co-hosted by HERD's partners, East Central and Southern African Health Community and the University of California, San Francisco. Earlier this month, on May 3rd, 2021, in her remarks at her USAID welcome ceremony, USAID's new administrator, Samantha Power, talked of the importance of promoting dignity. Dignity, perhaps best summed up in a simple borrowed phrase. Nobody is better than you, but you're better than nobody. Something we hear President Biden talking a lot about. The idea that every individual has equal worth. Every individual deserves to be treated with respect. USAID is proud and humbled by the achievements to date of country-led efforts to define the challenge, develop the policies, support the process of understanding how to provide maternal and newborn services that are respectful and dignified, and most importantly, to develop effective and sustainable solutions to complex maternal and child health issues. While we know that disrespect and abuse is disproportionately meted out to marginalized women, in personal conversations with local government authorities and Tanzanian elite, including women medical doctors, I have learned of their encounters with disrespect, which has even resulted in the loss of their newborn babe. So I am aware that this is a very personal issue for many. Only a decade ago, we barely had the language and data with which to describe the challenge of disrespect. Information was confined to anecdotes and individual experiences, and the prevalence of maternal mistreatment was unknown. We are conscious and appreciative that the leadership in advancing this work globally relied upon landmark studies conducted by East Africans, in particular in Kenya and Tanzania. After supporting studies to quantify and describe the problem and to explore solutions, we have started to consider how best to learn and share lessons about effective evidence-based packages of interventions that can be applied in the health system and community to address the inequities and injustices, which we have learned are disproportionately thrust on women who are young, less educated, and disempowered by their communities. We are also exploring ways to support country leaders, civil society, medical professionals, and champions to measure the results of these activities and identify ways of promoting their implementation at scale. USAID has seen a global awakening to the importance of respectful maternity care, even as this reorientation of the health service delivery system was severely tested over the past year with the chaos that the COVID-19 pandemic wreaked on essential services for women, newborn, and children. Building on our historical systems approach to promote an enabling environment for service provision, in our deliberations, USAID seeks more sustainable ways to advance the concept of respectful care so that both provider and client rights and needs are met, and neither is pitted against the other in a setting of limited resources and insufficient accountability. We look towards the learning that our partners are now leading to provide us with insights into meaningful ways in which respectful and accountable maternal, newborn, and child health services, voluntary family planning, and reproductive health care can be offered. We must endeavor that the voices of women and children inform the way in which these services are designed, that providers are not abandoned to conditions that are life-threatening and degrading, and that managers convene and lead gatherings in which solutions to the challenges of clients and providers are co-designed. These are some of the aspirations of USAID-supported MCHN programs. I'm sure that your contributions today will help shape the future of service delivery and contribute to safeguarding the dignity of women, children, and families serviced by the health system. I look forward to the deliberations. Thank you.
Thank you, Dr. Stevenson. I would like to now welcome Dr. Emily Pecker.
Greetings and a warm welcome to everyone. My name is Emily Pekka from the HERD Project at URC, and I'm going to provide a brief overview of the respectful care movement over the last 10 years in less than 10 minutes. As we consider if we are trending in the right direction, it's helpful to remember where we began. Let's look back 10 plus years ago. Poor treatment of women and families during facility-based childbirth was not a new phenomenon. We had anecdotes thanks to human rights organizations, flare-ups of outrage, but little documented evidence making it hard to mobilize action. Just over 10 years ago, maternal and newborn health colleagues at USAID actively grappled with how to make treatment during childbirth, which was viewed as a soft and not well-studied topic, something that could be taken more seriously. As a starting point, USAID, through the Translating Research into Action project, commissioned a landscape analysis that demonstrated disrespect and abuse was a problem larger than any individual anecdotes and concerns. Appreciating poor experiences occur beyond childbirth, the emphasis was intentionally placed on maternity care, given the vulnerability of this particular moment. The landscape, which has since been cited hundreds of times, was critically important because it provided a name and a frame for the problem. Having language about disrespect and abuse informed both advocacy efforts and the first research that endeavored to measure prevalence of disrespect and abuse. There is no universal definition of disrespect and abuse. Rather, we refer to domains or categories to describe it. The graphic integrates the categories from the landscape analysis and adds in categories reflective of the World Health Organization's typology. Here we see the emergence of the term mistreatment, thanks to WHO, which is used interchangeably with disrespect and abuse. Thanks to issue framing, cutting-edge research was able to both measure prevalence and describe the drivers of disrespect and abuse or mistreatment. We learned that the problem is caused by a confluence of sociocultural, health system, and interpersonal factors, to name a few. This underscores the fact that there is likely not one factor to blame in any given context, and therefore no silver bullet or single intervention fix to the problem. Our initial focus was around understanding and addressing disrespect and abuse, and then moved on to how to advance respectful maternity care. Appreciating, eliminating mistreatment does not automatically equate to achieving respectful care. To date, the issue has found a home in both human rights and quality of care circles. Notably, as you see on the left, experience of care is expressed as an equal component of quality, alongside appropriate provision of care in the WHO vision for quality. With time and momentum, we begin to see the language around respectful maternity care expand to include respectful maternal care, newborn care, etc., and extend closer to the client or people-centered care framings or other variations across different contexts. 5 or 6 years ago, it would be incredibly easy to quickly summarize all of the actions in this area. And now we find that it's virtually impossible to keep track of the proliferation of activity. On the left, you can see some highlights of key events, including those that laid the groundwork for the advancement of the issue prior to making this a priority at USAID about a decade ago. Since then, we've seen updated charters, regional resolutions, statements at the global level, global standards, the emergence of national policies and guidelines, advocacy campaigns, and an explosion of research within the last 10 or so years. So are we trending in the right direction? It seems clear tremendous progress has been made in terms of identifying, describing, acknowledging, and committing to the issue. However, there is much to be done in terms of the action agenda to ensure appropriate policy and program implementation and accountability. What we have heard from partners on the ground is, we understand this is an issue, but what do we do? And how can we routinely measure progress? We have an opportunity today to take stock of where we are and what still needs to be done. The HERD partnership supports activities in the areas listed here, and in particular seeks to advance priority setting, dialogue, and evidence generation and sharing to advance respectful care. Moving forward, we appreciate the need for increasingly inclusive, diverse, and more equitable partnerships, able to engage the necessary range of stakeholders and leverage linkages at multiple levels. We look forward to engaging you in this second decade of the movement, so please share your questions, priorities, and lessons learned. We look forward to this conversation and to hear your thoughts about whether collectively we are trending in the right direction, and hope you'll engage in discussions to follow. Thank you very much.
Thank you, Dr. Peka. Now, Dr. Patience Afulani.
Hello, everyone. My name is Patience Afulani. I am an assistant professor at the University of California, San Francisco. In the last few years, most of my work has focused on respectful maternity care, and today I will be speaking on some of our work on measurement. So for today's presentation, I will do a quick overview of measurement of RMC, but focus most of the time on how we have applied one of those measures, which we call the person-centered maternity care scale, in both research and program implementation. I will then end by highlighting some work we did to facilitate measurement of RMC for routine monitoring. Research on women's experiences prior to 2015 was mostly qualitative, which was important for highlighting the problem, but limited in assessing the extent of the problem. The few quantitative studies focused on disrespect and abuse, which was operationalized in different ways, limiting comparison across studies. The lack of validated measurement tools was highlighted in a systematic review, which identified about 36 instruments globally for measuring different aspects of women's childbirth experiences, of which they assessed 7 had good psychometric properties. 3 of these tools were broad measures of women's experiences, but none had been validated in low and middle income settings. Since then, there has been an increase in the number of quantitative studies on women's experiences of care. A more recent scoping review found over 170 quantitative studies with 157 unique instruments, about half were said to be validated. Most of these, however, they noted were for intrapartum care, with gaps in experience of care measures for abortion, antenatal, postnatal, and newborn care. Another recent review focused on psychometrically validated RMC measures, identified 4 scales developed since 2016, including the RMC scale, which was initially validated in Ethiopia, the PCMC scale that I will speak more about, and also the quality of RMC questionnaires that were both validated in Iran. Having validated tools means that they can be applied across settings, and this has various benefits I'll demonstrate using the PCMC scale. The PCMC scale is a scale that we developed and validated initially in Kenya to be able to quantitatively measure women's experiences of care during childbirth. In developing this scale, our goal was to develop a tool that was comprehensive, multidimensional, one that was theory-based, as well as valid and reliable empirically. We were focused on a tool that was appropriate for the setting we're working in, but potentially applicable to many other contexts. We define PCMC as providing maternity care that is respectful and responsive to women's preferences, needs, and values, per the Institute of Medicine's definition of patient-centered care. We chose to use person-centered over patient-centered because, as others have highlighted, patient tends to objectify and reduce the person to a mere recipient of medical services or to one who is acted on. Also, not all in the healthcare setting are patients. As Ekman et al. Note, person-centered care highlights the importance of knowing the person behind the patient as a human being with reason, will, feelings, and needs. And so we chose to use the term person-centered care. This definition of person-centered care highlights both RMC and responsiveness. But because RMC has also been defined very broadly to include responsiveness, we use the terms PCMC and RMC interchangeably in this work. And negative framing such as mistreatment, disrespect, and abuse refer to poor person-centered care. Person-centered maternity care also captures the experience of care dimensions highlighted in the WHO framework, including effective communication, respect, and dignity, as well as both emotional and social support. We followed standard procedures for tool development, which has been described in detail in the published paper. And this process led us initially to a 30-item scale based on the Kenya validation. The scale has 3 subscales measuring dignity and respect, communication, autonomy, and supportive care. And it has high validity and reliability. The items in the scale, which are listed on the slide, includes a mix of both subjective as well as objective questions. So a subjective question here would be a question on whether women felt they were treated with respect. Whereas there are questions that ask specifically, for example, were you allowed to have a companion of your choice during labor? And there are also questions that are more subtle aspects of PCMC, such as whether providers introduce themselves to women when they first see them. And we have more overt forms of poor PCMC, such as verbal and physical abuse. Each question on the scale is on a 4-point frequency scale, with most options including no, never, yes a few times, most of the time, yes all the time. And this frequency format is to enable us capture variation in terms of the frequency of which certain practices occur. Responses to the individual items on the scale can be combined and standardized, such that scores range from 0 to 100, where 0 is the worst care one can get and 100 is the best one can get. We have developed guidance materials on how to generate these scores, which you can access through my profiles page at UCSF. The scoring also highlights that women's experiences fall on a continuum from the worst possible to the best possible experience one can have, rather than as a binary exposure. Since the validation in Kenya, it has also been validated in India as well as in Ghana. The scale has utility for both research and programming, and I'll briefly share some examples of this. So start with comparing across settings and examining determinants. And we're able to do this because we had applied the same scale to 4 studies, in Kenya, rural and urban Kenya, in Ghana, and in India. And so, for example, we found that across all the 4 settings we had worked in, PCMC scores were below 70, that is 70 out of 100. But the lowest scores were in the domain of communication and autonomy, as shown on this graph. There's certainly room for improvement across all the domains, but communication autonomy was below 60 across all the settings, actually below 40 for the Ghana and India samples, indicating that this is a critical area that we need to focus on. We also found out the least occurring practices by looking at the various individual items. So for example, one of the questions we have is whether providers introduce themselves. And we find out that this is one of the practices that is often not done, with over 70% of women in all the samples saying providers never introducing themselves. So ranging from 77% in the rural Kenya sample to 98% in the India sample. Similarly, we see other gaps related to communication autonomy. So for example, whether providers explain procedures, we see that particularly in Ghana and India, many women are not being given information about procedures, examinations they are undergoing. Again, when you look at consenting, over a third across all the settings report that providers did not ask for consent. When it comes to autonomy, an example here would be being able to birth in the position of their choice. And here, particularly in Kenya and Ghana, we see that a large proportion of women reported not being able to give birth in the position of their choice. In addition, we're able to look at the factors associated with PCMC using these validated tools. And one of the things we find across the settings is that women who give birth in lower level health facilities, such as the health centers, tend to report better experiences than those who give birth in the higher level facilities like the district and sub-county, county, sub-county hospitals. In the settings where we have private facilities, such as in the rural Kenyan sample, we see that women who gave birth in the private facilities reported better experiences than those who gave birth in the public facilities. We also see some differences in wealth, especially we saw this in the rural Kenya and India sample, where the wealthier women tend to report better experiences. Another use of the scale is for needs assessments to identify areas that we should focus on for improvement, as well as evaluation of the interventions. So for example, as part of the SPARK project led by Dominic Montego here at UCSF, they use the PCMC scale to identify the areas to target for quality improvement, looking at the distributions of the individual items, and then use the scale for the evaluation to show that their quality improvement package led to changes in PCMC. And so they found that across time, the intervention was associated with an increase in total PCMC scores, as well as increases in all the subdomain scores in the intervention facilities compared to the control facilities. Similarly, we used it for the evaluation of an intervention in Ghana, which was focused on using an integrated training that included both obstetric emergency care and RMC simulations to improve RMC. And from the using the PCMC scale, we're able to show that there was an increase in PCMC from baseline to end line. There was no control group in this intervention. And we saw increases across all the domains. The biggest increase was actually in communication autonomy, which had the lowest score to start off with, in which the PCMC score almost doubled. In addition, we're able to look at the changes in the individual items, and with a few exceptions, there were increases in all the individual items. An advantage of using this scale here compared to a binary response option is that you can see subtle increases. For example, if something was occurring very frequently and it improves, it might not go to no never, but will probably go from occurring all the time to a few times, and having this gradation gives you more power to see change. We have gone on to adapt the scale. So one of the adaptations has been to develop a shorter version of the scale. So we have a 13-item version of the scale, which was developed based on the data from Ghana, Kenya, and India, as well as a prioritization survey. And we believe the shorter version can be more easily integrated into routine RMC monitoring. We have also adapted it for antenatal care. Unfortunately, the antenatal care version for LMICs has not yet undergone rigorous validation, and we're working on that to more adequately validate the scale for antenatal care. However, we have been able to develop an antenatal care version of it here in the US, focused on the experiences of women of color. And we have been able to adapt it again also to focus on the experiences of people of color in the United States. In addition, we have received requests for the guidance documents from people in about 20 countries so far who are currently using or plan to use the scale. And we have seen recent publications coming out from people who did not reach out to us, assuming, which suggests that there is potentially more use going on than we know, because the items are freely available in the publication for anyone to use. And some of the publications recently you've seen from Nigeria, Ethiopia, and Sri Lanka. So in conclusion, we know the magnitude of the problem. We know that measurement is critical to improving RMC. Most measures so far has been the context of research and donor-funded program implementation. And we need to move beyond measurement in only research context to continuous measurement for quality improvement and accountability. And the question we need to be thinking about now is, how do we get RMC into routine monitoring systems? To inform that process, we conducted a rapid review of RMC in 2020 to identify indicators that could be used for that purpose. That paper is published. We identified, and based on a rapid review and also a prioritization survey with RMC and maternal health experts, we identified 33 indicators that could be used for these purposes. Many of these indicators include the PCMC measures, as well as additional measures we identified in the review. But we know that just recommending indicators alone would not solve the problem, would not move the needle in that process. And so we need to think about, how can we support ministries of health? How can we support institutions in country to begin to integrate these indicators and their related data collection approaches into routine systems? And we are happy to engage with and support with such efforts. So thank you very much. I would like to acknowledge all our collaborators, the funding for all of this work, and all the support we've received for doing this work. I look forward to discussing and answering questions during the panel and subsequently. Thank you.
Thank you, Dr. Afulani. We will now turn to Dr. Chibugo Okoli and Ms. Lucy Chigwenembe to see how these tools have been used.
I am going to introduce myself, Dr. Ugo Okoli, the Deputy Country Director for JPIGO, and I will be presenting a brief case study of a project that we're doing in Nigeria that incorporates measurement of women's experience of care in maternal health and reproductive health program. I will also be presenting the challenges, opportunities, and lessons that we are learning as we're implementing. First of all, let me acknowledge our donor, MSD for Mothers, the federal government of Nigeria, and the 2 states where we're implementing. The implementing partners as well, JPIGO, MDOC, Health Strategies Delivery Foundation. And just before I go on, I just will give you a brief overview. Our overall goal for this project is to reduce maternal mortality and morbidity from indirect causes by applying a woman-centered quality of care model to improve prevention, early detection, and management of high blood pressure, diabetes mellitus, obesity, anemia amongst pregnant women along the maternal health continuum. These clinical areas are often associated with pre-eclampsia and eclampsia. The project is in 2 phases. Phase 1 that ran from 2019 to 2020, which is what I'm going to present today. And then phase 2, 2021 to 2022, which is ongoing. So the women-centered quality of care model has actually many implementation approaches, but I'm just going to share 2 of the components. The first component is working with the quality improvement teams at the health facility level to identify quality gaps, set improvement aims, and prioritize quality improvement indicators, one of which is the women experience of care. And the second part is actually to provide self-care support to some of the women registered on the digital platform to help them modify their lifestyles. So for the period of 1 year, October 2019 to September 2022, phase 1, we saw over 26,000 women using the health facilities with support in the ANC. And you can see from this chart that there has been a significant improvement from when we started in October 2019 to September 2020 of actually the proportion of women that are screened for these 4 clinical areas. So last year, in June 2020, we decided that we needed to incorporate the women's experience, to hear from the women about their care. So we set out to assess the quality of antenatal care and women's experience in receiving the services, and hopefully that this will inform the areas of improvement and approaches for regular measurement. We sampled 100 pregnant women enrolled in ANC that at least attended 2 visits, randomly selected them from 10 high volume facilities that are cut across general hospitals, private and primary healthcare. We administered a client questionnaire tool adapted with the permission from our Fulani et al., the 2019 publication. Data collection was done through RedCap and analysis was done by SPSS and Excel. So if you look at the first chart, which actually looked at the women telling us about the care that they actually got from the facilities, you would see that the women's reports in accessing the ANC best practices actually aligned with the many measurements that I showed you earlier on. So this was quite heartening, but however, there was still room for improvement and gaps that we needed to work on with the health facilities, such as doing more blood tests for the women at the appropriate time. But above all, provider communication of results remained low and will be targeted in the scale-up phase of the project as part of a larger emphasis on patient-centered care. We also went ahead to ask women questions around dignified care, privacy and confidentiality, communications, and then also facility environment. And again, there's room for improvement, especially around discussing things in privacy in the ANC. Women actually reporting that they felt, feeling of respect at all times, and then feeling treated in a friendly manner in the health facilities. All these results were fed back to the quality improvement teams for them to work on in terms of improving what they are doing. So we also are looking forward to the scale-up phase 2021 to 2022 in incorporating this as a regular measurement. So the facility exit survey that I just described will be extended from ANC to the delivery, PNC, and family planning as well. It will be done biannually. And then we will also incorporate finding out the perception of the women of the experience for those that are actually registered on the digital platform. The program is very, very keen and strives to monitor both clinical care and experience of care. And finally, there are, of course, a number of challenges, opportunities, and lessons being learned as we move on. So one of the challenges is actually getting the cooperation from health facilities to do routine respectful care measurements. And most of the excuse is that they have staff shortage and they are not able to engage in the whole process. Another challenge is finding an appropriate and convenient place to actually assess the women beyond the facility due to patient bias and location bias. And of course, COVID-19 pandemic challenges has actually had an impact in women's utilization of MH and RH services, but this is improving. So one of the lessons we've learned is that regular measurement of RMC is essential because it actually helps to improve quality of care at the facility level. We also now know that it is possible to monitor and improve quality of care and clinical experience of care and quality of care at the same time in a maternal and reproductive health program. Stakeholders and facility involvement is so crucial because we know that a collaborative process actually helps with acceptance of results and willingness to actually work on the needed improvements at the health facility level. We do have an opportunity within this project to test 2 distinct clients' questionnaire methods, the in-person exit survey for the health facilities and the patient digital platform survey. And finally, as we all know, staff shortage actually does lead to the motivation of staff at times and does negatively impact on respectful care sometimes. I would like to thank you for listening to me this afternoon. Thank you very much.
Welcome to Malawi's presentation on institutionalizing experience of care measurement in Malawi. I am Luce Gwenembe, the Chief Quality Management Officer for Southwest Quality Management Office under the Ministry of Health in Malawi. Malawi joined the MNH QC network in 2017, and then Malawi is using the MNH as a learning platform for implementing quality improvement program at a larger scale. So Malawi adopted the WHO MNH standards to Malawi context around the LALA framework. That's the leadership, action, learning, and accountability. So on accountability avenue, we are getting feedback from the clients using the Hospital Ombudsman platform and also annual client satisfaction survey. So the Hospital Ombudsman platform is a grievance redress mechanism whereby we want to involve our clients in their care. We want to get their feedback and then use that to improve the care which they come and get from our facilities during their next visit. In the platform, we are using the people from administration or from environmental health. We chose these people because they don't provide direct patient care. So we want to have someone who is independent. So the program is being run in collaboration with the National Office of the Ombudsman. The platform has a strategy which we developed together with the National Office of the Ombudsman, whereby this strategy guides our implementation. But now to zero in on the patient experience measurements, we are using the platform to get feedback from the clients through the exit interviews. Like the Hospital Ombudsman get the information from the walk-in clients who come and give their feedback, like if they have complaints, but also from the Hospital Advisory Committee, from the suggestion boxes, but also the Hospital Ombudsman are encouraged to have their phone on 24 hours. So some complaints, they come through phone calls. And also the Hospital Ombudsman is encouraged to be proactive. So they go around the facilities to do inspections to make sure that if there are issues, they have to collect them before the clients come and complain. On experience of care, that we have the Hospital Ombudsman who routinely collect feedback from the clients on monthly basis through the exit interviews, but also we get the experience of care from our clients through the periodic annual surveys. It is our wish to be conducting annual surveys in each and every facility in Malawi so that we complement the information that we get from the Hospital Ombudsman on monthly basis. The main issues or the main questions which are asked on this client feedback questionnaire, which they use for the exit interviews, they check on the waiting time, but also we get information if the clients were involved in decision making, if the treatment was explained to them, but also want to get information from the clients on the cleanliness of the facilities, ask about informal payments. And then for our postnatal mothers, we asked about pre-discharge counseling, if they had a birth companion of their choice during labor and delivery. But apart from that, we'd also want to ask the clients directly if they're satisfied with the services that they have received. All this information is analyzed, and then the information is used for quality improvement. On the reporting system, like when they found these issues, when they have interacted with the clients, the urgent issues are reported to the facility in charge. On monthly basis, the Hospital Ombudsman is part of the quality improvement support team. So they analyze their information and present to them, whereby these issues or the resolutions are being taken and included in the quality improvement plan for the following month to make sure that they are responsive to the client's issues. And then also on monthly basis, the Hospital Ombudsman reports are entered in the DHIS tool. So for the complaints, they are managed according to the protocol, or those complaints which are above or beyond the Hospital Ombudsman, they are referred to relevant authorities. So the monthly reporting form, like the first part is about the complaints or the issues. So they enter it according to department, whether it's maternity, outpatient department, under 5 department, or general inpatient department. So they indicate the number of cases which they have each issue. And then after that part, they also indicate on the complaint resolution, user satisfaction. And then for the maternity clients, they also asked if they have received pre-discharge counseling for the mother and also the baby. They also compile the data for the companionship. So this data is entered in the DHIS on monthly basis. There are also some challenges that they are faced by the Hospital Ombudsman. So the major issue which they face is the lack of cooperation by some staff members. Even though the members of staff were oriented or briefed to the platform, but some they are still not happy because they take the platform as maybe they are spying on them, on how they perform their activities. You find that there is no cooperation. And then on the periodic annual surveys, most of the partners, they were doing the periodic annual surveys to check client satisfaction, but also to get their experiences. So what Malawi did as a country, we harmonized the two. We get all the tools from the partners, but also us as a government, we checked on what is it really matters, and then what are the issues that we want to include in our annual client satisfaction survey tool. But of course, like we agree that, okay, we call it an experience of care so that we can get as much information from the client. And then, as I've already indicated, we rely on partner support to conduct on our annual surveys. When you look at the care which is provided in our wards, in our departments, only 7% were dissatisfied. So we also checked on the satisfaction of the facility environment. Like 42% of the clients indicated that they are not happy with the sanitation in the toilets. So we still have room for improvement. And then when we look at what is it that we have learned from this platform, we have seen that the Hospital Ombudsman platform and other available feedback mechanisms can significantly contribute to improved quality of care in the health facilities. Even though, as I've already indicated, that not all service users utilizing the platform. In that catchment population, you find that there's only one facility. So the clients at times are afraid that if we complain the next time, maybe we are not going to be treated well because maybe the providers will have grudges on us. But we have also learned that good working relationship between the HO, facility management, and also the health center management committees is very important to address the complaints, but also to improve the quality of care, because we involve the communities, we get the community issues, but also the facility, we get their views. And then as a hospital ombudsman who is handling this platform is directed on how best they can work around the issues to improve the quality of care. But also we have learned that regular supportive supervision is required to enhance the hospital ombudsman capacity through mentorship and coaching to strengthen their functionality. As you have said, that like this is just an added responsibility. At times they concentrate on their role. So when we are supervising them, we are guiding them and then coaching them on how best they can handle the platform. So this one we do also to strengthen that they report on monthly basis in the DHIS, but also they do their monthly analysis, because we want to involve our clients as much as possible, that we get their feedback and then we use that feedback to improve the quality of care. So I think that's how we are measuring the experience of care in Malawi currently. Thank you so much.
Thank you to Dr. Okoli and Ms. Chikwenembe for presenting those case studies. Next, we will be looking at some of the promising approaches for addressing respect for maternity care that have emerged.
Hi, my name is Nadia Diamond-Smith, and I am going to be presenting some work with collaborators from URC and I'm at UCSF, and this is part of the HERD project. And I'm going to be presenting on our findings of a scoping review of respectful maternity care related interventions. So just a background, as we all know, the prevalence and incidence of RMC and DNA has been documented, and there have been a range of interventions. However, we don't know a lot yet about what types of interventions have been implemented and which type of interventions should be implemented. And we also know that different terms and framings are often used to describe and contextualize RMC. So the aims of our study were to identify and disseminate a summary of some of the promising approaches for RMC interventions in Africa specifically, and to explore a little bit more about terms and frames used for RMC and RMC-like approaches. So to do this, we used two different methods. The first was a rapid scoping of published literature and gray literature, and this informed both of these two analyses. And then also we did a crowdsourcing exercise where we sent out a survey through our network, and hopefully some of you received that survey and responded to it. And from that gathered some more information about interventions that were going on right now. Just to provide a little bit more detail about our three methods. So first we conducted a literature search, and this was of gray and published literature. And from this, 21 interventions were identified. And these were ones that did something to promote RMC and address DNA, had to be an intervention. We were focused only in Africa, and between 2009 and 2020. And then the second approach was the crowdsourcing survey. And from that, we were able to get a total of 12 complete or mostly complete entries, again, from Africa. And then we also integrated a search of Ministry of Health websites. And from that, we're able to find 16 strategic plans and guidelines. So some of these, there were some overlaps. So in total, we found 43 unique different interventions across 16 countries, and our timeline was focused between 2009 and 2020. So as you can see from this map, most of these were interventions or approaches were happening in East Africa. Tanzania had the largest number of them, and we can see that there's been a large increase over time in the number of interventions that we identified related to RMC. So we looked through all of these 43 interventions and categorized the type of intervention into 9 different approaches. So the first is training healthcare personnel. So this includes training them on the importance of RMC, effective communication, informed consent. The second group was around facility level improvement, so check-in processes or clean bathrooms or private examination rooms. The third was around supporting the wellness of providers, for example, resting areas with tea. The fourth around implementing some type of quality improvement program, such as routine M&E. The fifth was on changing government or global policies and guidelines, such as incorporating MNC into national training guidelines. So those were all sort of supply side related interventions. And then we had a group of demand side approaches. So the first of these was some type of approach advocating for RMC. The next one was around educating birthing persons. And then the third was around some type of engaging community members, either health workers or companions or family members. And then the final group was something that sort of combined the supply and demand side, and these were some type of social accountability mechanism. So as you can see, the majority of interventions that we identified incorporated some type of training healthcare personnel. So the blue line is where that was the only approach in that intervention. And then the purple is where there was multiple different approaches within one intervention. So most of the approaches that we identified did include multiple different ways that they were trying to intervene to improve RMC. Facility level improvements were also quite common, as were some educating birthing people or engaging community members. This just shows the single versus multiple interventions and at different levels. So we can see that a number of the interventions we identified were just working in one community or one facility. There were quite a few that were also working in multiple communities or facilities, and then fewer that were in multiple countries or at the whole country level. We reached broadly to not just look at the time of delivery. However, the majority of interventions that we identified were focused right at the time of childbirth. However, a number of them also had some either targeted women in the pregnancy period or postpartum, or even reached into the newborn and child period. Very few encompassed even a broader lens of family planning or some other type of health service. So since the trainings were most of our interventions included some type of training component, we decided to look at those a little bit more closely. You can see that most of them were situated in East Africa. Most of the training did involve some type of other approach. So 75% of them, 15 out of the 20, incorporated training plus something else. Most of them were specifically focused on, had RMC or DNA specified as a primary objective. Most of them focused on clinicians and other non-clinical workers. Unfortunately, there was not a lot of detail about what actually happened in the training. So this is, future research should give us more information about what they're actually doing. But of those that we did have information on, most of them seemed to involve some type of interactive design or role play. And a large majority of them either occurred over multiple days or had included consecutive series of trainings with ongoing mentorship or support. So moving on, we thought it would be interesting to look at how people are talking about RMC and how that's changed over time. So the different bars here show titles and abstracts of publication that either use the term RMC or disrespect and abuse or mistreatment or experience of care. So we can see over time, of course, there's been an increase in publications using all of these terms, but it seems like more and more people are talking about respectful maternity care. That's that yellow bar, which we can see is increasing pretty steadily over time. And we matched that alongside some of the main policy documents or that have been, statements, global statements that have been published over time, just to see if there's any relationship between how, people are talking about this in the larger global domain versus in their publications. And then looking more closely at the framing people are using in their as they're talking about their interventions and the policy documents. So the majority of interventions that we identified talked about quality of care or cited the quality of care framework as sort of the basis for their intervention. A number of the interventions, specifically less so for the policy documents, talked about a rights-based approach or cited the universal rights of childbearing women. Experience of care and social accountability were also mentioned a fair bit. And a large number of the interventions and policy documents that we looked at talked about more than one framing. So in summary, we found that of the work that's happened in Africa on interventions for RMC, most were in East Africa, in Tanzania especially. Most focused on training healthcare personnel and facility level improvements. Most interventions were multi-component. We did not, just to highlight, we did not look at the effectiveness of these interventions in this study. In terms of terminology, over the past decade, there's been a large number of an increase in the number of publications in this area, and RMC seems to be the dominant term used. And in terms of framing, WHO Quality of Care Framework and the Respectful Maternity Charter Universal Rights of Childbearing Women seem to be the most commonly used framings. Thank you so much for your time and looking forward to more discussion later in this webinar.
Thank you, Dr. Diamond Smith. We will now examine some regional examples of promising approaches. I will now welcome Dr. Muna Abdullah and Ms. Ellie Finglas.
Hi, good afternoon. My name is Muna Abdullah. I'm a health system specialist working for UNFPA East and Southern Africa Regional Office. I would like to share with you UNFPA's experience in promoting respectful maternity care in East and Southern Africa region. To give you a little bit of background, for UNFPA, zero preventable maternal deaths by 2030 is one of the three corporate transformative results. As a result, we have a UNFPA regional program which ran from 2018 to 2021, which defined an output indicator on number of countries with guideline on respectful maternity care in place. And this is the first time we had at the regional level an indicator on quality of care, particularly on respectful maternity care. We have been monitoring mostly service availability of services, but in 2018 we recognized the importance of including indicator on experience of care. How we intend to do it in the future also is to improve access to quality services by following systems approach. For UNFPA, we have a pillar of program on preventing maternal deaths is on midwifery, and we have a number of midwifery-led programs. This includes strengthening midwifery program at primary health care, community and facility level, maternal and perinatal day surveillance and response, integrated care following a life course approach, preventing fistula, emergency obstetric care, access to basic and comprehensive emergency obstetric care, and the component which I highlighted in purple is the quality of care, which mainly focuses on respectful maternity care. UNFPA East and Southern Africa works in 23 countries highlighted in the map, and we did an assessment of the midwifery workforce in the region, and we have more than 125,000 midwives in the region. What we do at the regional level is build capacity of midwives on respectful maternity care using various forums. Example, this picture you see is in 2019, where there is an Africa Midwifery Conference, which was organized in collaboration with International Confederation of Midwives. There was a specific training on respectful maternity care, which was a one-day, full-day training pre-conference, and UNFPA documented around 95 midwives have attended this conference. We have also interagency collaboration with the WHO and UNICEF offices for improving quality of care. And As you know, WHO have revised the intrapartum care, which has a component of quality of care and experience of care. And in that experience of care, we work closely on promoting respectful maternity care. We also contribute to the UN Special Report on violence against women, focusing on disrespectful maternity care. Policy guideline at country level, we support countries mainstream respectful maternity care in national guidelines. For example, Kenya, Ethiopia, Eswatini, and Namibia, setting a service standard. For example, when countries revise their antenatal care, we provide technical assistance to mainstream respectful maternity care on these guidelines. For example, Namibia has revised their antenatal care in 2020, last year. We do also pre-service and in-service training, such as EMOC trainings in South Sudan and Kenya. In Zambia and Malawi, we support midwifery associations to advocate for respectful maternity care. For example, they have annual celebration of International Day of Midwives, and different countries advocate respectful maternity care in different ways. There is also an opportunity where countries revise their curriculum, midwifery curriculum. We support mainstreaming of respectful maternity care. Ethiopia is an example. Lesotho, when they do gap assessment for the midwifery training, we specifically try to highlight the importance of respectful maternity care in these assessments. Zambia has done the midwifery curriculum revision last year, and respectful maternity care was advocated to be part of the curriculum. In Ethiopia, we also support to ensure that respectful maternity care indicators are regularly monitored through the health sector monitoring framework, and this is an example. They have managed to include one indicator on respectful maternity care for their annual health sector review. This picture is a panel of midwives from intergenerational midwife, a retired midwife, a young midwife, representing different contexts, having a dialogue, and these forums is used to promote respectful maternity care. Like we are doing also now, we join hands with like-minded agencies such as the East Central and Southern Africa health communities to promote respectful maternity care. And lastly, measuring respectful maternity care has been a challenge, but what we have done is at regional level, we developed a synthesis of evidence on respectful maternity care. So the challenge is some countries have a standalone national guideline on respectful maternity care, and others, they have integrated respectful maternity care into their national guidelines, such as reproductive RMC, reproductive health, sexual reproductive health national guidelines, or any kind of other trainings like EMOC training. So this is my last slide, and the next step is in this region, we know that respectful maternity care is, the awareness is there. Some countries are at different level, but the collaboration has to be strengthened. A lot of initiatives and efforts are in place, and this collaboration should be strengthened. Expand our intervention on quality of care. There is also a lot of emphasis on quality of care. Evidences are coming up that access to skilled birth attendance is increasing, but it's not contributing to reduction of maternal mortality, and the main reason given was a poor quality of care. So mainstreaming respectful maternity care in this quality of care initiative would be an opportunity for us. Close collaboration with professional associations. We are working with midwifery associations, and others are working with different professional associations. I think this would be also a key to roll out respectful maternity care. Continue generating evidence and data to drive programs, as we are trying to do now. UNFPA regional office is developing its regional program 2022 and 2025, and we are planning also to really focus on respectful maternity care in the regional program. Thank you very much.
Hi, everyone. My name is Ellie Feinglass, and I'm one of the co-directors of Namati Mozambique. Again, I wanted to give a little bit of context on Mozambique. As I think is the case with many countries, rights awareness is very low. Many people simply don't know what to expect. They don't have adequate information about the health services that they're supposed to receive. The culture of silence and the fear of retaliation are also very powerful. The fear that if, for example, if I complain or seek redress today, then tomorrow the nurse may not treat me well when I come with my sick child. It's very real. Patients have very few opportunities to provide feedback or voice complaints, and those that do speak up rarely receive a response or redress. So when these experiences accumulate, sometimes over the course of years, people lose trust in the health system. Health workers, too, become resigned to working within the limitations of a broken system rather than seeing themselves as agents of change. Even mundane challenges that are seemingly simple to resolve often go unaddressed. For example, delivery room functioning in darkness for months because of a burned out light bulb. Namati's work grew out of this recognition that how patients experience the health system, the manner in which they're treated, and whether or not their voices are heard matters profoundly to health service utilization and to health outcomes. And that to advance the right to health, we need to build the power of patients and frontline providers. So Namati is on the ground as of today. We're on the ground with 41 health advocates in 68 health facilities across the country. We're in 4 of Mozambique's 11 provinces. And I sort of put health advocates' work into 3 buckets. The first one is raising awareness of health rights so that patients can more effectively advocate for themselves. We do this via regular in-person meetings, radio and TV programming, and dissemination of a range of educational materials. Health advocates also work to facilitate dialogue to make the health system more accountable to the communities that they serve. Health advocates work to revitalize and build the capacity of what are often inactive village health committees. And together with these committees and with the communities, we implement quarterly participatory health facility assessments, which is a methodology that we designed and have found to be really, really effective in proactively identifying many barriers that prevent people from seeking and accessing the care they need. And we document and resolve specific challenges. We sit down with the village health committees and health workers to analyze the root cause of each of the problems, agree on strategy, and commit to concrete actions and timelines. Health advocates also support patients and health workers to speak up and address barriers that undermine human dignity and access to care. So on any day, a patient can approach a health advocate and report a challenge or a barrier that they've encountered, and the health advocate will help them seek redress and follow up. And this includes grievances related to infrastructure, equipment, supplies, health worker behavior, etc., and then engaging authorities to find a solution. And we always try to work at the lowest level possible to find solutions where problems occur. Shows the grievances we've registered since 2013 actually through December of 2020. And you can see that the majority, or 20%, almost 20%, 18% have been related to rude or disrespectful treatment. We've been able to resolve 82% of these grievances. And we've seen an average reduction of 43% in these types of violations at health facilities that have health advocates working in them. How do we go to scale, or how do we have impact beyond the areas in which the health advocates are working? One way we've really focused on is by building the capacity of government to ensure equitable and humanized health services. Our health advocates document every case they handle, including the details on the nature of the grievance, actions taken toward resolution, and outcomes. And in the aggregate, data from these cases provides really invaluable insight to government on how the health system is working in practice. And it's a really powerful lever for system-wide change. We've been able to impact policy nationally, including the first national anti-bribery policy in the health sector and a national strategy for the improvement of quality and humanization of health services. And we've helped the Ministry of Health design a number of health provider training modules on human rights and ethics, a training module to help establish patient rights offices in every health facility across the country, etc. We also have worked a lot with civil society partners to carry out this work via training and mentoring and ongoing assistance to these partners. And starting, I think it was in 2019 and 2020, we helped train and mentor the prime recipients for human rights for the Global Fund. And now currently we are supporting 40 CBOs across the country to take on some of this work in provinces where we are not currently covering. So now we have sort of coverage across the country through these partnerships. I'll stop there, and I really look forward to hearing from everyone else, and thanks very much.
Thank you all for those important insights and remarks. We will now play a short video entitled Stakeholder Soundbites with Dr. Lily Keck, followed by an exciting update from the White Ribbon Alliance.
Respectful maternity care is about respecting two individuals, the mother and the newborn at the time of birth. One of the important changes made in the updated Charter for Respectful Maternity Care is the clearer articulation of the actions needed for both the mother and the newborn. Yet it is easy to gloss over the actions for the newborn with the assumption that respecting the mother will automatically confer respect on the newborn. Respect for a newborn begins at birth, yet a quarter of the world's children are not registered at birth. Birth and death without a trace is disrespectful. Care of the newborn does not end at the time of birth. It continues for a full month. We are beginning to examine more closely the prevalence of abuse, neglect, and mistreatment of newborns during their first month of life. We are learning that stigma, mistreatment through neglect, and non-compliance with standards of quality care are quite common. As we increasingly focus on the small and sick newborns, who are the most likely to die or the most likely to survive with disabilities, we are being much more strategic and deliberate about integrating an evidence-based bundle of care that is family-centered, compassionate, and developmentally supportive. Abuse, neglect, care that is not responsive to the newborn's cues, not sensitive to the pain felt by the newborn, inadequate nutrition when the newborn is unable to suckle, and separation from the mother or family are just some examples of actions that can hamper the development of the newborn's brain. So yes, go ahead and cuddle that baby, shower her with baby talk, but also be strategic and deliberate about the evidence-based bundle of services that is nurturing and developmentally supportive. Respectful newborn care is a core aspect of this bundle of nurturing care and fundamental to the baby's development. It will be important to identify the right indicators to measure the newborn's experience of care, the processes of care, and the impact on the newborn's development. Thank you.
Around the world, women, adolescents, and families have long voiced what we need, what we want, what we deserve.
We want quality care, including respectful and dignified treatment, with means to redress wrongs.
We want clean health centers and schools with running water and toilets.
We want health workers, especially midwives and nurses, who are respected and supported so they are better placed to provide respect and support.
We want to feel safe, whether at home or in a hospital, with those who are meant to care for us.
We want equal protection and promotion of our rights, including sexual and reproductive rights, no matter who we are and what we represent.
We want essential information, supplies, and services for sexual and reproductive health, for maternal and newborn health, for child and adolescent health, within reach during an emergency and every day.
Our demands are not new, but perhaps the world is finally ready to truly listen,
to act, to invest in a way never seen before.
To let the voices of communities light the way out of this pandemic and into a more healthy, equitable, and prosperous world for all.
Women voices count. In 2018, over 1 million women from 114 countries spoke their truth about the one thing they want most for their own reproductive and maternal health care. What women want: power in numbers, power in words.
For our last speaker section, I would like to introduce Sister Ziada Sela.
My name is Ziada Sela, the Director of Nursing and Midwifery Services, currently working with Ministry of Health, Community Development, Elder and Children. In Tanzania, actors have produced a growing body of literature and have tested some of the promising practices is spoken about today. In the policy, we create and cooperate RCC principles and national policies and regulations, so that to make sure every nurse and healthcare provider abide on this policy. So in the community level, we have tried to engage them, so to make sure that the community accountability, especially on the angle of confidentiality, feedback mechanism, and also the education, is to make sure everybody in the community knows about RCC, and also they can use this because they'll know their rights. Also, they can get time to provide feedback to the health facility or social leaders in the same community. Tanzania is home of a growing number of stakeholders. We have a lot of stakeholders which we committed to advancing respective and compassionate care. And many thanks to our previous Minister of Health and Dr. Makuani, who is the Assistant Director on the RCHS, for adoption of nursing and midwifery guideline, the national guideline for gender and respective care, mainstreaming and integration across RMC services in Tanzania, and inclusion of the issue in the One Plan 2. Now we revised sharpened One Plan 2, so we are going to the One Plan 3. We believe that nurses and midwives at the heart of health system can be the center of determining solution. That's why my directorate, we decided to, in collaboration with partners, to implement this respective and compassionate care at your level. Working together with the leader and central and local government, myself, I'm committed to serve as a champion and to support nurses and midwives and other healthcare providers to be catalysts for changes, to make sure RCC, it is strengthening, as I've said, from the primary level to the tertiary level. So we sensitize the regional administrative secretary, also directors of the municipals and district, regional medical officers, DMOs, and medical officer in charge to incorporate RCC activity in the CCHP, so that it will be easier for them to implement and to evaluate also. They can evaluate monthly, quarterly, biannual, and annual to see the implementation of this RMC. Okay, recently we managed to conduct a 2 days meeting from 11th to 12th February, and a total of 249 participants from national, regional, district health facilities attended this meeting. And the meeting was included leaders from all levels. We have TAMAC, RMC, Tanzania Nursing and Midwifery Council, and the Tanzania National Nurses Association, tutors, but also Tanzania Midwifery Association, but also included the development partners. And during this meeting, we conducted a lot of activities, but the main agenda was how to implement and strengthening RCC and RMC at all levels. And the expected outcome was nurses and midwife leaders to understand their roles, challenges, and the opportunity on provision of RCC and RMC services. We as a Ministry of Health, first of all, we have initiated the system which is called the Afya Maoni, and this system used to capture a suggestion, and if there is any complaints from the communities, they have access to enter all complaints in this Afya Maoni system. We have started with 2 regions, but now our plan is to make sure we scale up at all 26 regions in mainland Tanzania to send a feedback mechanism from the health facility to the community, but also from the community to the health facilities, to conduct biannual meeting with the community leaders, but also representative from the community to get feedback from them on the services we provided, if there is any challenges, so that we can sit together and make sure we get the solution of the problem which happened to one of the health facilities. So what we plan to do, first of all, is to make sure we capacitate nurse leaders and midwife to conduct a comprehensive supportive supervision and to provide mentoring and coaching for the feedback identified during the supportive supervision. After conducting the training, we need to do the follow-up to make sure they implemented what they've been trained at the previous, but also to prepare and accommodate RCC and RMC indicators in DHIS2 and the Health Information Management System, so that we can know where we are and we can get we can measure if we are improving or we are going down. We are continuing to collaborate with stakeholders to inform basic practices. For now, we are working with the Africa Academy for Public Health, IAPH, through the HEAD project to launch an information sharing platform that houses respective care resources. Also, this will help us to get information on the RCC. The challenges, as we know, we are dealing with a human being. The challenges, especially on attitude, and we are trying hard to make sure they will change. But for now, we are still getting some problem among care providers. But we believe as time goes, they will adapt to RCC, RMC. But also, we are getting a problem on inadequate teamwork to effect change on agreed RCC services. That's why we are planning to make sure every RMO, DMO is incorporate RCC activity in their CCHP. But also we have a shortage of funds, which limits us to scale up orientation of RCC training. Our next step in advancing RIC, first of all, as I've said before, we need to capacitate leaders and to strengthen quality improvement team at all levels, so that they can get time to evaluate what they did, to evaluate how healthcare providers provide these services to the different clients, but also to strengthen the discipline committee, but also in collaboration with the director of the policy and the planning, we need to develop the M&E indicator. I think here we'll collaborate also with the IAPH to make sure that we have this indicator, and also to prepare documentaries of success stories and share it at all levels to make sure everybody knows about the RCC, the community, the health facilities, but also to conduct a follow-up of postnatal follow-up, because nowadays when mother gets discharged, when she goes home, there is no good mechanism to make sure we are going to follow up these mothers. So we are trying to, we have planned to initiate this postnatal follow-up up to 48 days after deliveries. And lastly, what I want to say, nurse and midwife are the heart of the health system, should be the center of determining solution of any challenges in the health settings. Thanks very much for listening. Wishing you all the best. Thank you.
Thank you, Sister Ziada. We appreciate your words, and thank you to all of the presenters here this morning, this afternoon, wherever you find yourself. I have to say I'm humbled by the work that we have heard presented today, and certainly there has been a lot of discussion, a lot of questions in both the chat and the Q&A. I certainly will probably not be using the questions that I had prepared for this because there are so many great questions in the chat. I recognize we only have 10 minutes left. I know some people have already had to start dropping off. I want to let everyone know, you may have seen in the chat that we intend to make this recording available on a number of sites, including the HERD Implementation Science YouTube channel. It will be available on the Advancing MNCH website, and we will also be sending out each of the panelists an email that shares how and where you can get follow-up. I'm struck that certainly by the activity that's gone on in both the Q&A and the chat, and I apologize, I don't know if I introduced myself. I'm Dilys Walker, also from the University of California, San Francisco. And before we launch into the brief Q&A, I also just want to thank all of the organizers, the partnership that is involved not only in producing this webinar, but in this movement, I think is a lot of what drives its power. And I'd like to really thank USAID for their support and leadership in this effort. Even though it began 10 years ago with some important work, it is still clearly very early, and we have a lot still more to do, particularly around this area of interventions and how to actually make birth safe, kind, and respectful for everyone. So I'm going to ask the panelists that we have, Dr. Chibugu Okoli, who you've heard from, Dr. Nadia Diamond-Smith, Ms. Lucy Chigwenembe, and Dr. Patience Afulane to put their cameras on, because we're going to do a quick Q&A with those. And I think what I'm going to start it with is something that one of the presenters alluded to early on. You know, this is a movement that began more than 10 years ago. It has had lots of momentum. There are many people working on it. And something that I have been seeing, and I'm sure many of you have also, is that the COVID pandemic that has hit all corners of the globe is really, many people were thinking it would impact facility-based delivery and antenatal care. And we're finding that that is pretty well maintained, but what we are seeing is many more reports of mistreatment and abuse and problems with the experience of that care. Maybe I'll just ask, I'll start with Lucy Chigwenembe and see if you have any thoughts that you can share about whether you think that the COVID pandemic has caused this lots of movement backwards rather than forwards.
Thank you so much. Like for the case of Malawi, like when we were hit with the COVID-19, at first we saw like a drop in the antenatal care attendees. Of course, it was that women were afraid to get the coronavirus from the health workers, but also the health workers themselves, they were also afraid. So when the ministry noted that, like they sensitized all and also encouraged mothers to continue assessing the antenatal care, because like we thought and we said like maybe the effects would be so grave than the COVID itself if people are not attending the antenatal care. So we saw a change, but still women were still not comfortable. And even now after the antenatal care, when they come to the clinic, let's say like to get any injection, they're afraid of being given the COVID-19 vaccine. So like we find that like in the labor wards, people are afraid of getting the oxytocin after birth and all those. So like those are some of the effects that we are seeing and facing in Malawi. But for the antenatal care, we sensitize the women, and then we have, of course, seen the lives, but at first there was a drop of attending antenatal care in our facilities.
Thank you very much, Lucy. Appreciate that. I think it's there has been lots and lots of interest in discussing interventions. There's been discussions in how can we move this pandemic forward. One question in the Q&A that jumped out at me was from Mary Ellen Stanton that sort of said it best, saying that a big question that hasn't been directly tested, and that is focusing on grievances, mistreatment more effective than focusing on respectful care to promote a more positive experience of care over time? And I think this also gets at a number of questions in the Q&A about the language and the terminology. And I'm going to throw that one out there. I'm going to first ask Patience what you think about, you've really looked into this, and then I'll turn to Nadia and see if either of them this terminologies and framings. This is probably a much longer conversation, but I'll let you get started.
Yeah, I mean, there is no simple answer to that, right? I think Emma brought it up in the chat that we needed certain terminology initially to sort of highlight the urgency of the problem, and using terminology like disrespect and abuse, obstetric violence, sort of highlighted the urgency of the problem. But we also know that it's not in all spaces that we can start off with that language. And so I think that use of the terminology is more of something we should be thinking about in specific context to realize which language do we need to use in this context to gain entry. So sometimes you might want to gain entry with more subtle language, like talking about poor quality care and getting people who all recognize that quality of care is important before you begin to highlight that poor quality care also includes respectful maternity care. And we don't have respectful maternity care, and we have women experiencing disrespect and abuse. And so I would say it's not striving to have the same language. I think the terminology we use will differ depending on the context. And for us working in this space, being cautious about which language will gain us entry. And then once we gain entry into certain spaces, then thinking about what language will highlight the urgency of the problem and drive people to act.
Thank you, Patience. I knew you'd be able to tackle that one. Nadia, how about you? Anything to add?
I mean, I agree with what Patience said and think that that's, you know, an important way to start this conversation. And I think just to add on to that, just making sure that the decisions about what language to be using in a certain setting or context are reflective of that community or population, and making sure they're sort of not being imposed by funders or some type of outside force, because I think that there's, you know, who's deciding what language to be used at a different time is something that we need to think about carefully.
Thanks, Nadia. I'm going to turn this to Dr. Chibugo Okoli. I noticed there were a number of questions in the chat that were around this issue of the community voice and community advocacy, and how do you sort of promote, support the community and recognizing their rights and driving some of that demand. Do you have any thoughts on that for us?
Okay, thank you, Dilys. I saw those questions. And you know, the community voice is also very, very important in the arena of RMC. And there are various ways you can do that. And one of the ways is actually taking out time and working together with the community stakeholders to actually raise their awareness, build their capacity in terms of how they can actually ask for their rights. Another way to do this is as also part of the quality of care work that you do with primary healthcare facilities. And I talk about primary healthcare facilities because that's the one that is nearer the community and located within their communities. One of the ways is actually to ensure that they're engaged or part of memberships of quality improvement teams at the facility level. And in that way, you know, the ministry or the partner that is actually supporting the ministry can use that means to also build their capacity in terms of their input and the way they take things forward on behalf of the people that they are representing in those quality improvement team meetings, which actually happen monthly when you actually set them up. And of course, the issue of also from time to time going out there and also asking the women their perspective, because women are also part of the community as well. And who better place to actually go out there and ask the question. There was a very good presentation on community voices. I've forgotten one of my colleagues that did that. And I'm sure that participants will really like to review that and see ways that you can include community voices. Thank you, Dilys.
Thank you very much. And I'm just being cognizant of the time. I just want to reiterate that we will make this recording available in multiple sources. And if you signed up for the webinar, you will receive it, and link to some other resources. We will look to find other ways to continue this engagement and continue this dialogue. I think partnership and collaboration is going to be our fastest way to the end point. And for those of you who can hang on, I'm going to end this with one last question that I was going to ask first, and we'll see if the panelists prepared for it, because it will take that very minimal time. You have 5 words or less. In 5 words or less, what is the most critical, core element, important mechanism that you think will drive sustainable change? You have 5 words. Our time is up, so 5 words. We'll start with Patience.
Okay, I would say we need to reduce burnout, motivate providers, and hold them accountable.
Thank you. Good. Well done, Patience. I like that. How about you, Dr. Chibugo Okoli?
Okay, I would say engagement and commitment from key stakeholders to work on this. Yeah.
Thank you. And Lucy Chigwenembe?
Thank you. For me, for sustainable change, we will rely on self-motivation, awareness, and accountability on clients' dignity. Thank you.
And Nadia, what do you think?
Well, I was going to say engaging women in the process from the beginning. That might be more than 5 words, but keeping it woman-centered when we're making things.
Women-centered, keeping women in the center when we're women-centered. I like that. I love it. I have really appreciated this opportunity I've had to work with HERD and to work with all of you. And again, we will be in touch, and thank you very much for joining us, and thank you for everyone's involvement, you participants as well. I'll leave you there. Until the next time. I believe what I was supposed to mention, I know you're all leaving, that we have 2 more webinars coming up, 2 in June. One will be around evaluation, and one will be on the Advancing Postpartum Hemorrhage Care program that we have. So please stay tuned and you will get information on those. Thanks very much. Bye-bye.